Today we are glad to have Ajahn Kanika. She is going to tell us about her recent paper, Payment Mechanism and Hospital Admission Evidence from Thailand. Thank you, Ajahn Kanika. The floor is yours.
Okay, all right. Thank you very much. So today I'll give a talk on my paper entitled Payment Mechanism and Hospital Admissions Evidence from Thailand. This is a joint work with Cartier Atley at University of Sydney. Yeah. I think we are all familiar with this chart. And this is the SDG goals that countries around the world are trying to achieve in year 2030. And if you look at goal number 3, yeah, this is to ensure healthy lives and promote well-being for all and all ages. And if you look deeper into target 3.8, yeah. So what we're going to see is that it's saying that countries should try to achieve universal health coverage, yeah, including financial risk protection for its citizens. So what we are witnessing is that many countries around the world are trying to expand universal health coverage to their citizens. And I pulled this graph from The Economist. And what we are seeing here is that the percentage of population with public or private healthcare insurance coverage is increasing for all countries. And in Thailand, you can see the kind of orange graph. Yeah. By early 2000s, we have almost 100% of our population covered by some kind of health insurance. Okay. And this is happening in many countries around the world that, you know, they're trying to expand health insurance coverage. So as a result, what we are seeing is that there is escalating healthcare costs everywhere. And governments around the world, they're trying to find ways in order to control or to reduce these healthcare costs. One such way is to change payment mechanism such that if you induce the providers or the supply side of the healthcare market to save costs or to use their resources more efficiently. So one way is to what we call the diagnostic related group based payment, the DRG based payment. That is a payment method that basically hospital will receive fixed amount of payment for each admission that depends on the DRG classification that the patient is receiving or is assigned by the physicians. And this DRG classification is really based upon principal and secondary diagnosis that the patient received, and it can be adjusted for patient's age, sex, presence of comorbidities, and complications. Okay, so essentially, with this DRG-based payment, what we are assuming is that patients that get the same DRG code, they basically have similar health problem, health condition, and they will receive similar type of treatment, yeah, from the provider, and they will consume similar level of resources, yeah, and presumably they will have similar length of stay, yeah, at the hospital, and that's why hospital received fixed amount of payment, yeah, for that admission, okay. So when we look at a paper by Matt Tower and Wittenbecher in 2013, they're trying to review the current stage of this DRG implementation in low and middle income countries. And what they find is that as of 2012, there are about 12 low and middle income countries that already implement DRG, yeah, and about 17 others that are in the piloting stage. Okay. However, when we go and try to conduct this review, what we find is that most of the studies that have been done on the topic of DRG have been done for Western developed countries. There are only a few studies that have been done for high income countries in Asia. And some studies have been done for China, which is the upper middle income country. And these studies usually focus on a specific hospital or a specific city or evaluating DRG at a piloting stage. And that's why this comes to the main contribution of our study. So the first contribution that our study made to the literature is that we used 9 waves of nationally representative data. So this data is 2003 to 2015 Health and Welfare Survey, and it's spanned across 12 years period. And we're trying to assess the impact of DRG for Thailand, which is a middle income country in Asia. Our second contribution is that we're trying to assess patient at a city level or at a specific hospital. Yeah. Our third contribution is that we look at 5 main outcome variables in this study. So we're going to be looking at the impact of DRG on hospital admissions, frequency of admissions, length of stay, out-of-pocket inpatient expenditure, and also the type of hospital that patients have been admitted to. Okay. So this is the outline of my talk today. I'll start off by giving you some background about different health insurance in Thailand. And I'll talk in details about this payment method change that occurs in the Thai setting. Then we'll go into literature review. And then I'll present the research methodology, what type of model we are using. Then I'll show you the data and give you definition of variables, present the estimation results, and finally give you conclusion of our study. So in Thailand, we have multiple health insurance. Yeah, I'll be talking about 3 main public health insurance schemes in Thailand. I think the first one that we probably most familiar with is the Universal Coverage Scheme, which in this paper we call it in short UCS. It got started since year 2001. And the main target population for this particular scheme is people who are in the informal sector. About 73% of the population are covered by this particular scheme, and this scheme is financed by general taxation. There are both public and private healthcare facilities that are the providers under UCS. However, the majority are public providers. In terms of provider payments, provider get paid under UCS with the closed-ended payment method. So in particular, for outpatient care is like you go to have doctor visit, but you don't stay overnight at the hospital. Basically, the provider get capitation payment at the beginning of the year to give any type of outpatient treatment to the patient. And for inpatient care, which is for hospitalization, provider under this scheme get paid based on DRG, diagnostic related group as well. The second scheme is the Social Security Scheme, which is in short in this paper we call it SSS. This scheme got started in 1990, and the target population for this scheme is private formal sector employee. And this is about 15% of the population that are under SSS. This scheme is financed by contribution. So the employee pay 5% of their salary. Yeah, employer pay another 5%, and the government match another 2.75% into the fund. In terms of providers, there are both public and private providers under the scheme. As of 2018, there are 237 contracted providers under SSS. Yeah. For SSS scheme, provider get paid by closed-ended method. So since the beginning of this scheme, provider basically get paid based on capitation. So they get fixed amount of money to treat both outpatient and inpatient care to the patients who register at their hospital. For inpatient care, providers start to adopt the DRG-based payment or SSS scheme. And then finally, the last scheme that we'll be focusing on in this paper is this Civil Servant Medical Benefits Scheme, which we call it CSMBS in this paper. This scheme got started in 1980, and the target population is government employee, their spouse, their parents, and up to 3 children aged below 20 years old, and the retirees from public sector, they are covered by this scheme. About 7% of the population is covered by CSMBS, and the source of financing is general taxation. The providers under this scheme are mostly public providers. Beneficiaries under this scheme can go to private providers when there is emergency. In terms of provider payment, if it's outpatient care, provider basically get paid through open-ended payment method. So we usually call this a fee-for-service payment method. So that means when the patients come and whatever procedures that the provider has done on the patient, the provider can pretty much get reimbursed on all those procedures. And that's why we call it open-ended. However, for inpatient care, there was a recent change from open-ended approach towards closed-ended approach, which is the DRG based payment that got started in July 2007. Yeah. So that comes to, this policy change that we want to study in this paper. So in July 1st, 2007, for inpatient care, there was a switch from a retrospective fee-for-service payment, which is an open-ended approach, towards a per-case DRG-based payment, which is a closed-ended approach. And this has been done for the CSMBS group. Yeah. So we want to study this particular policy change. Okay. So what's the theoretical consequence of this, policy change? Well, this DRG-based payment definitely is going to affect the supply side of the CSMBS market, the provider side, because now from provider point of view, the price per admission of each patient is now fixed, right? The key is you get fixed money for treating the patients. So provider have incentive to save costs, and they also have incentive to increase efficiency because they would like to avoid losing money. Yeah. And hospital may also have incentive to reduce length of stay. So you want to treat the patient as quickly as possible and then get them discharged out of the hospital to save your costs. Yeah. The hospital may also have incentive to reduce intensity of healthcare services. So this you could think of like, hospital might not want to conduct as many lab tests, or they might not want to conduct as many X-rays or MRI on the patient to save their costs. Yeah? So reduce intensity of care. There might also be some unintended consequences as well. For example, there might be unnecessary admission to increase the patient's volume. There might be early discharge and planned readmission to increase revenue. Yeah. Hospital also might have incentive to admit low risk, low cost patients in order to minimize the financial risk that they are confronted. Okay. So then we move on to conduct literature review to look at empirical studies. And our focus is basically empirical studies in Asia because it should be relevant to our context. So we find that there are some studies that have been done for high-income Asian countries like Japan, Korea, and Taiwan. So I list some of the paper here. And there are some studies that have been done for a specific city or specific hospital in China. So I list some of the paper here. Now, what's the summary that we found from the lit review? Well, if you see in this table, if we look at the outcome of length of stay, yeah, so you see that there are some paper that find that DRG-based payment has significant impact and it actually reduced length of stay, yeah. But there are some paper that don't find any significant impact of DRG on length of stay either, yeah. If you look at the outcome, which is medical expenditure, similar thing, what we find is some paper discover that DRG has significant impact by reducing medical expense, but some paper don't find any significant impact of DRG payment on medical expense. In terms of hospital readmissions, we find that one paper, Himadat et al., they discovered that DRG leads to significant increase in readmission rate, but Chang et al. And Jian et al. Don't find any significant impact. So what we are getting from this, this literature review that we have conducting in Asia is that there is mixed finding in terms of how this DRG-based payment impact various outcomes. And that's why there is room for more studies at the national level that we're trying to conduct here, okay? So now I'll come to our research methodology. So we're going to be using difference in difference methodology to study this policy change. And I think a lot of us here, we're familiar with this approach, yeah? You need to have a treatment group. So it's the group that undergone the policy change. So in this particular setting, our treatment group is the CSMBS beneficiaries, yeah, because there was a policy change that is being done on them. So previously, for inpatient care, provider get paid based on fee for service, which is an open-ended approach. Starting July 1st, 2007, this payment method has changed towards DRG, which is a closed-ended approach. Yeah. For control group, we have two different controls. Yeah. So the first one is the universal coverage scheme beneficiaries. So this UCS group, again, for inpatient care, provider get paid based on DRG ever since the start in 2001, and there's no change until now. And the other control group in this study is the Social Security Scheme, the SSS beneficiaries. So the SSS group, provider basically get paid by closed-ended approach, yeah, since the very start. However, it was a capitation payment all along until 2005 that the provider payment get changed to DRG, okay? So in this study, we're going to use both UCS and SSS. So we're going to use UCS alone, SSS alone, as well as combined UCS and SSS together as the control group. Then this table is trying to present the timing of the policy and how we actually divide our data into the pre and post period. So any data that, you know, that happens that got collected before July 1st, 2007, we count them as the pre-period. So for HWS, the pre-period data consists of 2003, 2004, 2005, 2006, and 2007. So I think you might have a question, why 2007 HWS is the pre-period? Because the data got collected during January to June of 2007, which is prior to the date that the policy got implemented. Yeah. And then the post-period data consists of 2009, 11, 13, and 2015 HWS. Okay. Okay, now come to our research methodology. So we are using difference in difference estimation. The first equation here, I think we're all familiar. Yeah. Y is our outcome of interest, which in this study, we have 5 different outcomes that I mentioned before. So we're going to look at hospital admissions, frequency of admissions, length of stay, out-of-pocket inpatient expenditure, and the type of hospital that patient get admitted to. Yeah. CSMBS is basically a dummy variable for treatment. Yeah, this is a treatment group. Post is also a dummy variable for post-policy implementation. We also include the interactive term between treatment and post-dummy. Yeah, and the coefficient associated with this interactive term is what we're most interested in because it's capture the effect of payment method change. We also control for various confounding factors, which are in this X. Yeah, so we're going to include age, gender, marital status, educational status, region of residence, and so on. Okay, and epsilon is the error term. For the second equation, basically, what we do is instead of including just the post-period dummy, we include each individual year dummy variable. Yeah. And we use 2003 as the reference year because that's the first year of our data. And we also include the interactive term between treatment and each individual year dummy. Okay. So again, our interest is on this coefficient beta 3. Okay. Okay, so our data, again, it's 9 waves of HWS survey, yeah, and this comes from National Statistical Office of Thailand. This is a repeated cross-sectional data of nationally representative household. All members of the household, they were interviewed and asked about their health services utilization, medical expenditure, health insurance, self-reported health status, and socio-demographic factors. Okay, so let's come to our variables. So this table is trying to present the definition of our outcome variables. Hospital admissions is basically an indicator variable that takes the value 1 if an individual has any hospital admission during the past 12 months prior to the interview. For frequency of admissions, is the number of times a person has been admitted during the past 12 months. Length of stay is the length of stay or number of days that the patient has been in the hospital during their last admission. Inpatient, our pocket expense is the amount that the patient paid out of their own pocket during the latest or the last hospitalization. And then finally, type of admitted hospital. Basically, we create 4 different indicator variables for 4 different levels of public inpatient healthcare facilities here. So we have community hospital. So we have a dummy, for whether or not a patient got admitted to community hospital during the last admission. And usually community hospital is the hospital at district level and provide primary and secondary care. It usually have about 10 to 150 beds. Another a higher level from community hospital is general hospital. So we create another dummy for whether or not a patient got admitted to general hospital. General hospital is usually hospital at provincial level, and it has about 200 to 500 beds. At the public hospital, we also create another dummy for other public hospital. So you can view this hospital as hospital belongings to Ministry of Defense, Royal Thai Police Hospital, State Railway of Thailand Hospital. And then finally, the highest tier of public hospital in Thailand is the University Hospital. Okay, so University Hospital, as we know, it has the most advancement in terms of medical equipment. Okay. Now, our explanatory variables. So these are, the X that we're trying to control for in our regressions. So we have age. We create several dummies, for age, and the age group that we consider in this study is the working age group. So it's the age of 23 to 59 years old, because we want to make our sample, the treatment and the control group, to be most comparable as possible. So we just limit our study towards working age sample. That's what I mean. We have a gender dummy. We have marital status dummy variables. We have several categories for education. We have a dummy for whether or not a person is employed. We have categorical variables for different regions that a person lived, and a dummy for whether a person is in municipal area. Okay, so let's look at our summary statistics. So this table, we're trying to summarize different variables by different insurance groups. So we have CSMBS, SSS, and UCS, and we summarize the statistic by pre and post period. Okay, so let's take a look at age. So age here is saying that on average, for CSMBS people, pre-policy implementation, the average age is about 44.5 years old, and post-policy implementations, the average age increased to 46.5 years old. And you can see that the average age seems to increase for all insurance group, for SSS and UCS as well. For gender, it seems to be quite evenly split between male and female for all health insurance group. If you look at employed here, this is the percentage of people who are currently employed. So again, this is saying that if you're seeing this summary stat is saying that for all insurance group, we are seeing that on average, the employment is increasing. The percentage of people who say that they are employed is rising between pre and post period. Education also, similar picture here. We are seeing that on average, there is increase in education in our sample all insurance. Show you the summary of our outcome variables, our dependent variables. So let's start off with hospital admissions. Okay, so what does this number mean? 0.07. So it's saying that for a CSMBS person, some CSMBS beneficiaries during the pre-implementation period, there is about 7 percentage points in terms of hospital admissions. So this is saying if there are 100 people, about 7 people are admitted to hospital during the pre-policy change. And for the post-policy change, the number becomes 0.04. So this is 4 percentage points. So it means that if there are 100 people, on average, there are 4 people who got admitted to hospital if they are CSMBS group, okay? And we are seeing that there is this declining hospitalization on average for all insurance groups. And that on average, pre-period implementation, if you're a CSMBS, you have about 1.36 times of hospital admissions per year. And you can see that the frequency of admissions on average falls post DRG payment method change. Same thing for SSS group. There is a decline on the average frequency of admissions. But for UCS, there is a slightly increase in this frequency of admissions. Length of stay, you can see that 6.99 here means if you are CSMBS beneficiaries, on average, you have about 6.99 days of hospital stays before the policy change. And that figure becomes 5.93 days after the policy change. For SSS group, they also experience average decline in length of stays, and UCS group as well. Okay. Out-of-pocket expenditure here is saying that for CSMBS, pre-policy change on average, patients are paying about 1,881 baht out of their own pocket. And the number rise to about 2,370 baht post DRG payment method change. And we are seeing that for all insurance group, SSS and UCS, they're also experiencing average increase in out-of-pocket expenditure. For the type of hospital that the patient get admitted to, so what we are seeing here is that the majority of the people, they are admitted to general hospital. That's the level of hospital that the majority of the sample get admitted to. And regardless of insurance group, if you compare pre and post period, it seems that on average, there is a rise in admissions towards general hospital. This summary statistic, we haven't run any regressions yet, just to present and show you how our data looks like. Now, this is the result from our dip estimation. And just to save space, I just present you the coefficient of the interactive term here, okay? So here we have the outcome of hospital admissions, the outcome of frequency admission, length of stay, and out-of-pocket inpatient expenditure. And as I said, we control for different control groups. So the first column here, we combine the Social Security group and the UCS group together as our control. The second column, we only use SSS group as the control. And the third column, we only use the UCS group as the control, okay? So with respect to hospital admissions, what we are seeing here, this is the coefficient of the interactive term. You can see I highlighted in red, and you can see the figure is negative and statistically significant, So this is saying that if you are a CSMBS person, post DRG implementation, you are experiencing about 0.6 percentage point to 1.1 percentage point decline in hospital admissions relative to the control, okay? So we're seeing this significant reduction in hospital admissions post DRG change. Yeah. However, if you are looking at other outcome variables like frequency of admission, length of stay, or pocket expense of the interactive terms are statistically significant. So this result is saying that DRG change do not seems to have any significant impact with respect to frequency of admissions, length of stay, or out-pocket inpatient expense. Okay. Yeah, so there's a question that asks about parallel trend assumptions. So we're going to do some robustness check at the end. Okay, so I'll show you the results at the end. Yeah. Then we also look at the outcome, which is the type of hospital that the patients get admitted to. Yeah. So again, what we did here is we run, we basically create different dummy for different type of hospital. So the first regression here, we basically look at whether a person got admitted into community hospital or not. Yeah. So we run a regression for this particular admission, like for this community hospital admissions. And then we run another regression for whether or not a patient got admitted to general hospital. Yeah. Another regression for other public hospital, and then another one for whether or not a person get admitted to university hospital. So this is the result that we found in terms of our interactive terms. Yeah. So we find that when our control group is the SSS and UCS combined, and when it's UCS alone, our coefficient is positive and significant. But when it's just SSS, it's not significant. However, we try to argue here that the sample size dropped substantially when we just consider SSS as the control. The sample size dropped to about 1/4 of the full sample. Yeah. So let's focus on this positive and statistically significant coefficient. So this is saying that if you are CS-MBS group, post DRG implementation, you are experiencing about 10 to 11% increase in the probability of admitting to the community hospital, which is the lowest level of care in terms of public healthcare facilities. Yeah. When you look at other type of hospital, what we are seeing is that the coefficients of the interactive terms, they are negative and statistically significant. Yeah, so you can see in column 4, 6, 7, 9, and then 12. Yeah, so this is saying that if you're CS-MBS post DRG implementation, yeah, you're experiencing significant drop in the probability that you're going to be admitting to general hospital or other public hospital or university hospital. Okay. All right, so this is the result from our first regression. And if you remember, we actually have the second regressions that we control for each individual year dummy. And we also have the interactive term between treatment and each individual year. So what we're doing next is we run these second regressions, and then we get this coefficient beta 3, and then we plot this coefficient beta 3 for each year. Okay. So this is the plot of coefficient beta 3. So all this blue dot here is the beta 3 that we found for each year from the interactive term. And then we construct this 95% confidence interval around the coefficient. Yeah. And this is from the regression that we control for both SSS and UCS. Okay. So overall, what this is saying is that it's trying to capture the differential effect of policy change for each year, comparing to the reference year, which is year 2003. Okay. And this is saying that, because the 95% confidence interval, it has 0 in there. Yeah. So this is saying that if you compare, across this year with the reference year, we don't see any significant difference, yeah, of DRG impact with respect to hospital admissions in year 2009 to 2015 comparing to 2003. Okay. Oh, by the way, this dotted line here, this is the the timing of the policy change, July 2007, okay? But another thing that we are seeing here is that if you see the coefficient for the pre-policy change, they are all positive. And the coefficient for the post-policy change, most of them are negative, right? So this picture is basically telling us consistent result with the estimation result that we got from Deep Intake earlier, that on average, the post-period implementation returns relative to the pre-policy change period. We also do the same plot but for other outcomes, like we have frequency of admissions. So again, you can see that comparing to the reference year, the starting of our data, we don't see any significant difference in terms of frequency of admission for CS-MBS group post DRG payment change. Yeah, length of stay also very similar results. Yeah, so mostly you can see that we don't detect any significant change in LLS post policy implementation relative to 2003. Okay. And also out-of-pocket expenditure, post-period implementation, we don't see any significant impact in terms of OOP change comparing to the reference year, which is year 2003. Okay, so now let me just show you what we have done in terms of robustness check in this paper. The first thing that we did, if you remember when we talk about our control, yeah, the SSS group. We said that the SSS group, they had closed-ended payment methods since the beginning. However, in 2005, at the start of 2005, SSS switched from capitation payment towards DRG, okay? So just as a robustness check, we want to cut our data and just include the data from year 2005 onwards and to see whether, you know, our results still holds when we use subsample from 2005 onwards. Yeah. In other words, we want to show that our result is not contaminated by this switching of SSS payment method. Okay, so let me show you. Okay. So we run the same deep in dip regressions, but now just using the data from 2005 onwards. And you can see that the result is quite consistent with our full sample estimation. For hospital admissions, the coefficient of the interactive term, they are all negative and statistically significant. So again, this is saying that if you are CS-MBS group, post DRG implementation, you are experiencing significant drop in hospital admissions comparing to the control, okay? And then for the other outcome variables, frequency admission, length of stay, and out-of-pocket expense, the interactive term here, we don't find them to be significant, which is the same result as our full sample estimation. Yeah. We also run this restricted sample on the type of hospital that patients get admitted to as well. And you can see that our results here in this restricting sample, it's quite consistent with our full sample estimation. So again, this is saying that if you are CS-MBS, yeah, post DRG implementation, you are more likely to be admitted to community hospital, and you are less likely to be admitted to other higher level of cares like general hospital, other public hospital, or university hospital. Okay, so the same result hold. Another thing we did was instead of running each, regression separately for each type of hospital that the patient get admitted to, we also run an order logic model. So in this order logic model, our outcome variables has 4 levels. Yeah, the highest level is the university hospital, yeah, other public hospital, general hospital, and then community hospital. And you can see that the coefficient of the interactive terms here, they are mostly negative and statistically significant. So when it has negative coefficient and significant, this is saying that there is less chance that you will be admitted to the highest level of care, and there is more chance that you will be admitted to the lowest level of care, which is also consistent with our previous estimation. But I think one of the questions you might have, why don't we just present order logic? Actually, that's what we did in our first version of the paper, but then the referee basically mentioned that if you can apply dip in dip towards nonlinear model, it would require a lot more in terms of interpretation of the interactive terms. Yeah, so it's become substantially more complex when you're applying this dip in dip framework towards nonlinear model. Okay, so I think this one comes to address the question about parallel trend. So yeah, I think we all know that when we use dip in dip method, it's basically assumed that there is parallel trend between the treatment and the control group. Yeah. So what we want to do here is let's try to see whether we can somehow test this parallel trend. So what we did was we only consider the data during the pre-period, pre-DRG. So we only use data from 2003 to 2007. And then we kind of imagine that let's make an artificial treatment. Yeah. So let's assume, so the first column here, let's assume that there is policy change in 2004. Okay. And then we create the interactive term between treatment and the post dummy, which is 2004 onward. Yeah. Then we want to see whether does it pick up any significant impact here. Okay. If the parallel trend assumption were to hold, it shouldn't pick up any significant impact in terms of that interactive term because there is no policy change in that year. Okay. We do the same thing. We switch this artificial policy change year to 2005, yeah, and then we re-estimate the model, yeah, to get the interactive term. Same thing, we switch the policy change year, artificial policy change year to 2006, and then re-estimate the model. So the result we found is these are the interactive terms, the coefficient of the interactive terms, and you can see that none of them are statistically significant, yeah. We also do the same thing for the community hospital regressions here. And you can see that none of the coefficients of this artificial, none of the interactive term of this artificial policy change are statistically significant. So with this, we trying to argue that it seems that there is no change in the trend pre-policy change. Yeah, so in a way, we kind of confidence with our estimation. Yeah. Okay, so I think I present all my estimation results. Let me just give you the conclusion that we draw from this study. So what we find is that Drg based payment, yeah, decreased hospital admissions for CS-MBS group by about 0.6 to 1.1 percentage point. We don't see any significant impact on frequency of admissions, length of stay, out-of-pocket inpatient expenditure. We find that admissions to community hospital, which is the lowest tier of inpatient public facility, has increased by about 10%. And the admission to higher level healthcare facility has significantly dropped after the DRG payment method change. So our findings here basically can suggest that in the context of developing countries, it seems that hospitals are trying to guard against financial risk, not by changing intensity of care, yeah, not by reducing LOS, because our study didn't detect any significant reduction in LOS, but rather by becoming more selective in terms of whom they admit. Yeah. We don't find any evidence of increase in frequency of admissions. We don't see that there is any cost shifting towards patients. Yeah. And there is higher chance of admission to lower level of care and lower chance of admissions to higher level of care. And generally, when we think about different level of care, the lower level of care tend to be associated with lower costs. The higher level of care tends to be associated with higher costs. So we view this as another channel of cost containing measure as a result of this DRG policy change. So I think in sum, we trying to conclude that in the context of developing country, DRG-based payment seems to be an effective cost-containing measure. However, policymakers will need to weigh this against other adverse impacts, like maybe there would be possible decline in quality of care. There might be potential increase in unfavorable health outcome, or averted necessary hospital admissions. So those issues need to be studied in the future when more data become available. So that's the ending of my talk. Yeah, thank you very much.
ขอบคุณครับกุ๊ก thank you ครับอาจารย์กุ๊ก I think it's very very eye-opening for me who are outside the field ขอบคุณครับ thank you everyone see you in the next 2 weeks